Welcome. I'm Mandana Khalili, Professor of Medicine and Director of the UCSF Research Coordinating Center's Investigator Development Unit of the NIMHD Health Equity Action Network. I'd like to welcome you to our monthly training webinar. This session will be recorded. Today, we are honored to have Dr. Marilyn Thomas. She is my wonderful colleague who will speak to us on how anti-Black racism affects risk of chronic disease, COVID-19, and mortality. Dr. Thomas is a social epidemiologist investigating the mechanisms by which structural racism contributes to Black-white inequities in disease risk and mortality. Born and raised in San Francisco's Bayview Hunter Point district, she earned her bachelor's in microbiology and a master's in public health from San Francisco State University. She then continued her training as in doctorate at University of Berkeley School of Public Health and is currently a postdoctoral scholar in the Department of Epidemiology and Biostatistics and Psychiatry and Behavior Sciences at UCSF. She's an expert at integrating social theory, measuring racism as a social determinant of health, and estimating the intersections of race, socioeconomic position, and socio-environmental factors. Her research has focused on 3 domains of Black experiences that uniquely impact Black health. These are education, anti-Black law enforcement practices and policies, and negative racial bias or racial-based discrimination. Dr. Thomas, welcome to our webinars, and we look forward to your presentation. Thank you. And I will just wanted to express that we have a session at the end of the presentation for questions and answers, but please feel free to include your questions in the chat, and we'll be happy to take a note and address them at the end. Thank you again. Dr. Thomas.
Thank you, Dr. Khalili. That was such a great, warm introduction. I'm so grateful. Thank you. And I'm really happy to be here. Thank you for inviting me. I'm looking very forward to sharing with you some information about how to think about structural racism as a social determinant and how it's measured in the literature. So one thing I will disclose up front, I'm in an area where power has kind of been an issue, and it should have been resolved yesterday, but I just want to put that out there in case for whatever reason I get knocked off, and I will do my best to come back on. If I have to use my phone, I will. I don't think there's going to be a problem, but just letting you guys know ahead of time. Okay, so I'm going to go ahead and share screen. And then once I do, if I could get a nod from anyone so that I know you can see it. Yep, okay, looks like we're good to go. Okay, so like I just said, these are the things that we're going to cover today. So I'm going to talk about structural racism as a social determinant. I'm going to share some of the ways in which it's being measured and analyzed in the literature. And then I'm going to present 3 of my studies that how I take components of structural racism and link it to certain outcomes. And then I'll end with some of my ideas about what I think we can do about it before we get to the Q&A. Okay, so like Dr. Khalili said, I was born here. So this is San Francisco. I know people are from everywhere, but San Francisco, California, and there's a map on the left here that shows the racial distribution of San Francisco residents according to the 2020 US Census. And all of the groups are non-Hispanic except for Hispanics. So you can see this is our Asian residents that are in this royal blue color. You can see Black residents in yellow. We have Hispanics in this teal kind of color. And then we have our white residents in this kind of taupey brown. And I grew up here. So this is, we call it HP, but others call it Bayview Hunters Point. And Bayview is the most underserved, socioeconomically isolated, working class Black community in San Francisco. And you can see the large yellow cluster of Black residents here on the map. And in the Bayview, there are very few health promoting resources or wealth building opportunities, which has contributed to its residents being inequitably exposed to really harmful high risk factors of poor health. For example, This map on the right shows the median income reported in the 2020 census, and the higher incomes are in darker colors. And you can see that poverty is really high in the Bayview. In fact, the median income is about $30,000 for Black residents. And this is unlike predominantly, or more predominantly white communities like Pacific Heights. It's shown here with this large taupey brown cluster of white residents. And in San Francisco, the median income for white households is about $110,000, which is 4 times higher than Black households. And a large proportion of Bayview renters spend more than half of their household rent or income rather on rent. And you can see the higher proportions that are shown in orange here. And this map shows the medically underserved areas in red, which includes much of the Bayview. And that likely explains the huge disparity in premature deaths for Black residents compared to all other racial groups in San Francisco. And it's represented by the green squares here. So the top graph shows the years of life lost for males, and the bottom is for females. And in San Francisco, males die most early from homicide, but drug use is a major cause, actually, of premature death for both males and females. Now, this didn't all happen by accident, of course. It was by design. The map you see on the right is a federal and state sanctioned map used by the Homeowners Loan Corporation to outline the areas considered desirable and undesirable for mortgage lending purposes. And they called it a security map. So the green areas are the best, 1st grade, and the red areas are the worst, 4th grade. And this 1937 map of San Francisco was used to ensure that only white families were sold the desirable homes and Black and brown families were sold or rented the others. And it was usually at inflated prices. And this is a practice you may have heard is called redlining. And as you can see, the Bayview was among the worst areas, while Pacific Heights was among the most desirable. So if you just look at this shot, after nearly 100 years, you can see how deleterious the negative effects of redlining has been on Black and brown families in San Francisco and how it's impacted generations. I mean, Black and Hispanic residents continue to be overrepresented in the most marginalized districts of the city. And this is an example of structural racism, the historical and ongoing societal practices and norms that unfairly disadvantage people of color and unfairly advantage those who are white. And redlining is one way that we can conceptualize structural racism as a social determinant of health. Now, racism, as we all know, it's driven by racial prejudice, racial bias, and racial discrimination. And there are key differences between them. For example, we can think about racial prejudice as uninformed assumptions about members of a racial group, whereas racial bias is when members of a racial group are ranked by social status or value. So that means you could have a positive bias or a negative bias, right? And that's very different than racial discrimination. And this is when members are actually treated unfairly due to their race. So this is an action, not an assumption. And each of these forms of racism can be conscious, like you can know your bias, or it can be unconscious or implicit. And if you look at this image depicted here, we can see both racial bias and racial discrimination occurring at the same time. But both are independently important because one can knowingly or unknowingly engage in one form of racism and not others. For example, those who are like in a position of power, like an employer, can unintentionally engage in racial discrimination by hiring people who look more like them without personally holding any negative racial bias, like believing people of other races are bad workers. Now, structural racism isn't simply an assumption like this or even a single act. It doesn't even need to be perceived. So how then do we define structural racism? Racism is historically rooted in explicit laws and policies that date back to the very foundation of the US, which, as we know, was built on the genocide of Indigenous Americans, the exploitation of immigrant workers, and of course, the enslavement of Africans. And racism has been maintained through explicit policies and practices that have concentrated wealth building opportunities for white people or racially advantaged groups. And scholars have long argued that racism operates in multidimensional and complex ways, ranging from the individual to the structural. And although there is no standard definition yet, in recent work published in the New England Journal of Medicine, my colleagues and I have described structural racism as historical and ongoing interactions between macro-level systems and institutions that constrain the resources, opportunities, and power of minoritized racial and ethnic groups. However, the definition has evolved over time. So early on, Bonilla Silva described it as beliefs about certain groups that lead to discrimination. Powell described it as macro-level systems, social forces, institutions, ideologies, and processes that interact. And more recently, Bailey and colleagues describe it as mutually reinforcing systems. And although, this is an important note, although structural, systemic, and institutional racism are often conflated, structural racism is essentially comprised of three separate domains, which includes systemic, cultural, and institutional racism. And like before, each component of racism is, it has different qualitative constructs that are not necessarily interchangeable. And the important distinction serves not only to inform how we need to study structural racism as a social determinant, but also to better inform interventions to combat it. And if we think about this in the context of the socio-ecological model, which is this framework of overlapping rings showing the range of intersecting social forces that put people at risk of poor health, we can conceptualize these differences ranging from the systemic to the individual. However, for the purposes of our presentation, we're just going to focus on the upper three levels, all of which contribute to differential access to health promoting resources by race. And we can start with the systemic level. So systems of power generally regulate and organize the structure of its institutions, like our US system of government or our criminal justice system. So we can describe systemic racism as racialized systems of power that are seemingly colorblind, but ultimately are racially discriminatory. Cultural racism is societal norms, standards, and values assigned differentially by racial group, like what a professional hairstyle might look like. And institutional racism can be described as racialized laws, policies, and practices carried out by the state or non-state institutions that are racially discriminatory. And a lot of these policies are also seemingly colorblind. And an analogy from chemistry, this incredibly strong and stable molecule of carbon atoms that are organized like a soccer ball can really help us think about the strength and the interconnectedness of these separate constructs using structural racism, and we're going to use it in criminal justice. And so I'm going to present some of my findings regarding law enforcement. So compared to other developed countries, the criminal penalties imposed here in the US in our criminal system has led us to have the 6th highest incarceration rates in the world and disproportionate sentencing, fines, and bail for people of color, particularly Black Americans. And compared to white folks, Black folks are more likely to be stopped by police, to experience use of force, to be arrested, and to be convicted of a felony compared to, again, white folks. So if one is convicted, a felon can lose the right to vote, earn lower wages, and be denied student loan funding, housing, and employment. So all of these institutions get involved. And then news outlets and media sources influence the extent to which Black people are portrayed as dangerous or criminals, which in turn contributes to over-policing and higher rates of incarceration, and round we go. So these interconnected constructs work together to prevent the elimination of Black-white gaps in health and in socioeconomic position by reinforcing existing mechanisms or by generating new mechanisms for structural racism to maintain the status quo. And there's abundant evidence to show this or to support this mechanism. For example, this was really great. In a recent examination of structural racism in health in the US, Bailey and colleagues report this list of social and health inequities in the Lancet. And we can see differences in white compared to Hispanic and Black Americans. And I'll just briefly go down the list. You can see the first line is wealth. So median household assets is 10 times higher for white households in America, which has contributed to having or disproportionate rates of poverty for Hispanic and Black families or people. We can see higher unemployment rates, almost double for Black compared to white Americans. We see males incarcerated at much higher rates, 6 times higher for Black individuals or Black males. We see higher proportions reporting fair or poor health, which likely contributes to higher rates of mortality. This is related to diabetes and heart disease. So structural racism is considered a social determinant by governing which groups have more resources and more opportunities to build wealth, which drives inequities in power, socioeconomic position, and health. So when I'm asked why is it important to interrogate structural racism as a social determinant, put very simply, because racism hurts. And it doesn't only hurt minoritized people of color. It hurts white and other advantaged racial groups as well. And it's evidenced in public health research, some of which is my own that I'm going to show you today. And this is because regardless of race, human talent is equally distributed in our society. But racism ensures that opportunity is not. And that undermines the full potential of our society. And there is no reason to simply accept my anecdotal evidence in San Francisco or my experience as evidence that racism hurts. There are dozens and dozens of studies providing empirical evidence that various forms of racism and racial discrimination are linked to a wide variety of health outcomes and risk factors. And these are a few here, and I didn't highlight my own. These are works outside of mine. Now, in trying to understand how structural racism can actually get under the skin to impact health, we can use this conceptual framework. And there's a lot here, so I'm going to walk you through it. But it shows the indirect pathway between these higher level structural factors that I'm talking about, like the policies, the practices, the norms, cultural capital, socio-political capital, et cetera, that are linked to some more distal mediators from the outcome that are environmental exposures, like the neighborhood you end up living in, the access to the healthcare system that you have, your encounters with law enforcement, et cetera. And all of that is then mediated at the individual level, where when you're exposed to that stressor, let's say racial discrimination, you appraise that stressor. Is this a threat or is it a challenge? Like, am I in danger? And do I even have the resources to deal with the stressor that I'm exposed to? And each of those appraisals are linked to some psychological, physiological, and behavioral response that's then linked to some risk factor of disease that ultimately leads to our outcome of interest. And the promising news is that since 2019, there has literally been an explosion of new publications on structural racism and health, which is so good to see. You can see from 2020 to 21, it almost tripled. So that's amazing. But look at our past history. That is how little attention that racism has had in epidemiologic and public health research. So we're moving forward. And published last month, Ahmad and colleagues conducted a scoping review of the global evidence operationalizing structural racism as a social determinant in publications from 2000 to 2022. And here is the distribution of the study designs in that review. And you can see among the 54 articles or studies included in this review, 85% of which were in the US. You could see the vast majority were cross-sectional in design. So that was the most common, and that was followed by reviews. Most of the research was used quantitative approaches and mixed methods. And then following that was like qualitative research. But what's notable here is that we can see a gap in longitudinal study designs and those studies using causal frameworks, which is really needed to examine the causal drivers that can affect health essentially over the life course. Now, here's where the authors they put together among all the ways in which structural racism is measured in the literature as an exposure, they kind of made these different categories of how they clustered those exposures. But the takeaway is the most common exposures in the literature are racial segregation, housing, and socioeconomic and sociodemographic characteristics. Here you can also, well, when you read the review, there's a notable lack of availability of structural level data like policy indicators or those common practices and norms within institutions that we were talking about. So single dimensional exposures are typically measured at the individual or area levels. However, many researchers have advocated for the use of index measures to study kind of the multidimensional nature of structural racism. And index measures essentially integrate multiple dimensions of racism into one measure. And here are the most common. The top two were concentrations at the extremes and the dissimilarity index. I myself have used the everyday and experiences of discrimination scales. And the last two are listed here that were most common. And the most common outcomes were infant-related, quality of life, mental health, chronic conditions, and factors related to healthcare. And adding to this evidence last year, Adkins, Jackson, and colleagues reported on the most feasible and promising approaches to studying structural racism as a social determinant. And the big takeaways were presented in this really nice, succinct table. And I'm going to highlight a few. The first one being a really important one is the recommendation is to avoid using race as a proxy for racism. And I'm going to dig into this just for a quick second because it's important to understand that race is a social construct that is multifactorial. It reflects a hierarchical classification based on your cultural heritage, language, religion, skin color, among other characteristics that govern the distribution of risks and opportunities in our race-conscious society. But it does not capture the complex systems and institutions that govern that hierarchy and associated distribution of power. Another thing to remember is that race actually changes in different ways. For example, it can change depending on geography. So I might be considered Black in America, but I might be considered white in Brazil or indigenous in Canada. And it also can change with time. Like initially all Caucasians or all white people were considered to be Caucasians or vice versa. All Caucasians were considered to be white until there was a case in front of the Supreme Court indicating that Indian people are Caucasian, and then that changed. Irish were also considered non-white when they first came to the US. So it's important to keep these things in mind, but we don't want to use race as that proxy for these systems. But sometimes race is the only measure that we have, right? In public health research, we're often limited by our data. So if you do have to use race, it's a good idea to consider the intersection of race and some higher level exposure to an institutional exposure or a system level exposure. And in their example, they just happen to suggest race and redlining, which is the example that we opened with. So you know what redlining is, and that's a better way to capture structural level racism. Time is also a really important factor to consider, which I'm going to dig into in a moment. But first, I'd like to highlight this final recommendation, because we've talked about how structural racism, the exposure is complex and multi-level. So we need measures that can capture that complexity. And there are emerging methods, presenting novel methods to measure kind of that multidimensional nature of structural racism, each of which certainly have their strengths and limitations. And I'm going to show you one example, but before I do, I wanted to list some of the most common approaches, and they're listed here. And very briefly, people are using structural equation models, and they essentially identify constructs that are important, but not necessarily directly measurable. And so they do this by finding relationships between the observed characteristics and some latent construct. And an example of this would be like converting multiple socioeconomic indicators like income and education to one measure of a socioeconomic status or socioeconomic position. The two most common SEM, these like subsets, include latent class analysis, which is essentially it finds groups that are similar, like grouping alcohol users and grouping tobacco users, and factor analysis, which essentially it finds groups using correlations within the data. And multi-level and generalized equation models are commonly used to estimate cluster data, like considering neighborhood effects on individual level outcomes, or thinking about longitudinal changes over time. And this last newer method is very interesting. It's called META, and it's used to examine intersectionality by nesting individuals into social strata, representing all possible intersecting effects like your race, your gender, and other things, and then interpreting the model residuals as the additional effect. Now, regardless of the multidimensional approach, I threw this slide in here yesterday because I wanted to share some important concerns that I think about in terms of grouping unidimensional measures into one structural racism measure. One is that many indicators of inequality, like racial segregation, for example, can themselves be considered a consequence of structural racism, rather than a measure of it. For instance, racial segregation can be caused by racialized zoning laws like redlining or housing practices, in which case the segregation would be a consequence of that structural racism policy and mediate its effect on health. So researchers, we've been doing the best that we can with the limited data that we have, but clearly there's a need for more upstream indicators of structural racism as measurable policies and practices. And in addition, there seems to be very little causal mediation analysis in the literature to better understand these kind of complex direct and indirect mechanisms. And finally, many independent measures of inequality, like racial segregation or differences in Black-white income, are not necessarily independent from each other. So we must think very deeply and consider about the role of collinearity between our inequity measures and our specified model. But that said, despite these limitations, I do want to share one recent study using a really novel multidimensional measure of structural racism as an example, so you can see what I'm talking about. So these researchers used confirmatory factor analysis to integrate 7 area-level measures of inequity into one measure of county-level structural racism. And confirmatory factor analysis essentially empirically determines how each unidimensional measure is weighted in the composite measure. And you can see the list of the measures on the right here in this figure and the weights, essentially the weights along those arrows. And these researchers used this to make one county level structural racism measure, and then they estimated its association with BMI, and then considered the intersection of race and sex. And in their fully adjusted multi-level models with interaction terms, county level structural racism was associated with lower BMI, but that was for the referent group, which was white males. But interaction estimates with race and with sex show us that those in counties with higher structural racism, BMI is higher for Black versus white individuals, higher for females versus males, and the association was stronger for Black females than Black males. So measuring structural racism as this kind of multi-dimensional determinant of health can really provide additional insight into intersectional mechanisms underlying population health and equity, which is really what we're trying to get at. And a couple more notes, in addition to place, again, I'm going back to time being an important dimension of racism and discrimination. And with time, we can think about it in terms of frequency of the exposure, right? Like, is this something that happened once in my life, or is it like I'm experiencing this at work every day? And then there's duration, like in that moment, or is that workplace experience for years and years or just a couple of months? Then we want to think about the life course, and that's important because it could be patterned by age or exposures. Like, say I was exposed during childhood, but not in adulthood. And then you want to think about that critical period, right? If it was childhood, might that have impacted my cognitive development, my brain development, for example? And then latency periods, if that did happen, what might that mean later in life? Even though I may not be exposed to discrimination later in life, that early life exposure, what might that have on my cognitive functioning as I age? And then, of course, birth cohort is important because over time in our society's tolerance of implicit and explicit forms of discrimination vary, they change. So it's important to think about that saliency when you're considering mechanisms leading to your outcomes of interest. So another point and quick note is that structural racism can also impact more than one life course at a time. So there are also meaningful intergenerational effects that might be important to your research or what you're studying. And so I wanted to map this out in a way that we could consider an individual who is currently around midlife, so around 50 years old. So I rounded it, they'd be born around 1975. And if we consider an intergenerational span of 100 years, right, from 1920 to 2020, also rounding, there could plausibly be 4 generations of family members over 100 years. So if we want to think about intergenerational effects, I'm going to use my family's story as an example, because although I was born and raised in San Francisco, my father and his father were born in Paris, Texas. So let's have the first 2 generations be born in Texas and the last 2 here in California, and think about the exposures over these life courses that we might be able to think about. Just framing it that way, we have 2 of our 4, half of our generations here were exposed to legal racial segregation in the Jim Crow South. So that's meaningful. If we think about just this first generation and the exposure, we've got that homeowners loan corporation. If this first generation was born around 1925, the homeowners loan corporation, that policy was implemented in 1933, which was also around the same time as the Tuskegee experiment, which is important because that has a lot to do with the mistrust that the Black community has on government and in healthcare services, right? So I listed kind of along here some other commonly known potential policies and practices that differentially impacted people by color and by ethnicity. But the important note is that even though that happened to the first generation, it also happened to the second generation too, right? The second generation was exposed to some of these policies over their life course. And I put that red line there to show you the duration in which the redlining policy was in place. It didn't end until 1954, 1955. So that covered 2 lifetimes, determining where you work, where you can live, all of those things. Then we can see later in the 80s and 90s events that have impacted all 3 generations. And then we can see some of the crime bills that happened in the 1990s that also had implications for families of color, particularly Black men at the federal level with the crime bill. And here in California, we had the 3 strikes law. We also had a ban in affirmative action that went into the 3rd generation or the 4th generation, banning affirmative action in college admissions here in California. And then, of course, Obama became president. And we've seen some backlashes happen because of that with the Black Lives Matter movement and the white supremacy march in Charlottesville. And of course, the murder of George Floyd that has really impacted a social movement across the world. So using this diagram, you get to see how the exposure to structural racism has implications for individuals, but also generations. And it's important to keep that intergenerational complexity in mind when we're attempting to understand how structural racism may impact various health outcomes. Now, on a more positive note, that was a lot, we can also focus on sources of resilience for minoritized racial groups. Now, I will admit, social epidemiologists like myself, we often focus on risk models and risk factors, but we should also be thinking about phenomenon that may be health protective against the adverse effects of racism. And here are just some examples. We could think about this at the policy level, like what policies have increased access to resources and services and funding and neighborhood improvements. We can think about it on the community level, like what kind of initiatives have really increased community building or expanded cultural capital and economic empowerment. And then finally, at the institutional level, we can think about and look at practices and initiatives like DEI programs, diversity, equity, inclusion, the mission statement of an institution. How is that actually impacting practice? And then also internal evaluation. We should be reviewing and seeing how we're doing as we move along. And so that's why, as we said at the beginning, my work has focused on Black lives and experiences that uniquely impact Black health. And these are the 3 fields that I've kind of focused on. These are my kind of domains, even though I'm expanding. But I wanted to start with showing you some of the work that I've done investigating, well, I guess uncovering racial bias in policing. So in one study, I aimed to identify the law enforcement policies that may prevent avoidable police killings. So I examined US law enforcement policies as predictors of race-specific fatality rates. And very briefly, the data were from 2 sources, the Guardian and Lemus databases. So the Counted. The Counted is compiled by the Guardian newspaper, and it's a public use database of the total number of people killed by law enforcement during 2015 and 16. And there were a little over 2,200 people, sadly. But importantly, these data include the names of all of the agencies involved in each killing. Now, the Lemus database is a cross-section of government data collected approximately every 3 years from a nationally representative sample of all US law enforcement agencies, and it includes organizational characteristics like officer requirements and training. And that database had a little over 2,800 agencies. So what I did is to ensure that the agency policy was implemented prior to each police killing, I used the 2013 LEMAS database to match agencies linked to, fatalities in 2015 and 16. So multiple agencies could be linked to any given fatality. And the matching procedure resulted in a final sample of 451 agencies. They're involved in nearly a little over 1,000 deaths. And finally, I estimated incidence or fatality rate ratios adjusted for covariates. And as listed in the first column here, I selected 13 policies expected to reduce avoidable deaths like less lethal weapons use, as well as those expected to improve officer behavior like community evaluation. And in the columns from left to right, you see estimates for agencies involved in all killings, and then results stratified among agencies involved in white, in Black, and in non-white killings. And to be clear, this analysis compares fatality rates among agencies with a policy to fatality rates among agencies without the policy. So estimates below 1 reflect lower rates, which is our outcome of interest, right? So here's what we found. Only 2 policies predicted lower rates of all killings. But within racial strata, agencies with greater proportion of full-time personnel, established mission statements, community evaluation programs, and more types of personnel incentives predicted lower rates of police killings for white and non-white civilians. Increasing video use unexpectedly predicted higher rates of white killings, but most notably, no policies were significantly associated with the killing of Black civilians. Now, this work does point to some specific agency level policies that may be useful, but the important note here is that policies that specifically purport to protect Black lives, like community policing, less lethal weapons use, were ineffective, which is consistent with what we see in the media, right? So this does provide some modest empirical evidence of structural level anti-Black bias in policing. So then for me, the question became, how can we then measure anti-Black bias in public health research and estimate its direct effect? Well, one method is to use the implicit association test, or the IAT. And the race-related IAT is a computer-based test that measures the speed of keyboard associations between images of Black versus white faces and positive versus negative words like beauty and filthy, and faster reaction time between matching positive words with white faces and negative words with Black faces indicates cognitive dissonance between Black people and positive emotions, or implicit anti-Black bias at the individual level. So now I'm going to quickly share a study in which I used the IAT to investigate the effects of area level bias, anti-Black bias, on COVID-19 outcomes. An area level racial bias can be measured essentially by aggregating racial bias data from multiple individuals in a geographically defined area. So I estimated the relationship at the US county level, the relationship between implicit and explicit anti-Black biases and COVID-19 incidence and mortality that occurred in 2020. And to do this, I actually combined 3 databases. Very briefly, this is important. I think everyone should know about this database. Project Implicit is a large, publicly available data source on implicit and explicit biases about various social groups and topics. So any person with any internet connection can take an IAT at any time, except for right now. And the results of each test are added to the publicly available database of test responses. So we downloaded data for all non-Hispanic white respondents of the race-related IAT to assess implicit bias. And then explicit bias was measured by asking respondents to rank their feelings towards Black and white people. And then we aggregated over 700,000 individual racial bias scores to the county level. Now, overall death rates and incidence rates of COVID were calculated per 10,000 people using in nearly all US counties, but we used data from Johns Hopkins University. And then finally, we calculated Black, white specific incidence rates in almost 1,000 counties, a subset, using race-specific data that we actually secured, that was secured by the New York Times, but they shared it with us, so that was great. And listed in the first column, you can see the implicit and explicit anti-Black bias measures. In the columns from left to right, you can see the rate estimates for overall mortality and overall incidence. Then you see it for the race-specific incidence, and then the Black and white incidence rate gap. And we found that higher county-level implicit and explicit anti-Black bias were associated with higher mortality rates and higher incidence. For example, the second column shows that areas with higher bias had about 8 more cases per 10,000 people than areas with lower bias. Higher bias predicted higher rates of both Black and white incidence, so both Black and white people had higher rates related to exposure to anti-Black bias. And higher explicit bias predicted a gap such that for every 1 white COVID case per 10,000 people, there were 6 Black COVID cases. So this work adds, this is the important part, it adds to a growing body of evidence that structural racism is harmful for everyone, including advantaged groups. So if anti-Black bias is bad for your health, this is where we get into that sense of resilience. Like, so what about pro-Black exposures as potential sources of resilience against structural racism? And as many of us know, the literature consistently shows that educational attainment is health protective, particularly at post-secondary or college education. So I studied whether higher educational attainment would buffer the adverse effect of racism at the individual level. And several of my studies showed that it does. So my research has subsequently evolved into a deeper examination of structural racism in higher education, and I received a K99R00 grant to study the implications of historically Black colleges and universities, or HBCUs, on premature aging. And this study was literally published a week ago, like a week from today, in Alzheimer's and Dementia. And here, what we did is we examined the impact of attending an HBCU versus a predominantly white institution, or a PWI, on cognitive decline in Black adults. And we used pooled data from the Candle and Star cohorts. Now, each cohort includes older adults who reside in the San Francisco Bay and Sacramento areas who were members of Kaiser Permanente, Northern California from 1964 and 85. And they followed them up more recently for these cognitive tests. And our analytic sample included 716 Black participants who attended college. And we had 3 waves of cognitive tests from 2018 to 2021. And we assessed executive function and verbal episodic memory using linear multi-level models with age as the time scale so we could assess cognitive change over time. And it's important to note that the cohorts had different baseline ages, 65 for Candle, 50 for Star, and I'll explain why that's relevant in a minute. But this figure shows the adjusted standardized beta coefficients for the college effects at mean age 70, with executive function in purple and verbal episodic memory in magenta. Now, compared to PWI attendees, HBCU attendees averaged better executive function and better verbal episodic memory at baseline. But as you can see, the confidence intervals were wide and neither association was statistically significant. And this figure shows the adjusted annual rate of change from mean age 70 for executive function on the left and verbal episodic memory on the right. And change in executive function didn't really differ. And then initially we found that HBCU attendees averaged slightly faster decline in memory, But when we restricted both cohorts to age 65 at baseline, because remember, STAR was age 50, so there was a lot younger individuals, there was no rate difference when we restricted it. So the big takeaway here is that these findings do suggest that less exposure to structural racism in higher education may influence premature aging in Black adults. So what does all this mean in terms of structural racism research? First, it's important to know that law enforcement policy may reduce avoidable killings, but the policy predictors themselves may vary by racial group with little to no benefit to Black civilians. Second, anti-Black racism is likely harmful for everyone, such that interventions could actually even help, advantaged groups would benefit from an intervention. And third, educational attainment may be protective against the negative effects of racism. And last, evaluating HBCU exposure or sources of resilience, specifically HBCU exposure, because it's an experience that may offer the benefits of educational attainment without increasing exposure to discrimination, is an unexplored and really important research priority. And I'd like to close with sharing some thoughts about what we can do to mitigate racism as a public health threat. First, we have to stop doing this. If we are to address these issues, we have to listen to each other, we have to be open-minded, and we have to have real intellectual honesty about what's going on, and we can't do that for just talking to each other. So I'm hoping we can stop doing this, no more of that. And that's why I'm really happy to be here, because this is one of those spaces that I'm hoping can be a safe space to have some dialogue around the implications of racism in our lives and in our field. I also think it would be a really good idea to start promoting resources like the IAT within social institutions of power, like law enforcement and schools, so that we can know what our biases are if we are to address them. Again, continue to address the ongoing inequities that we already know contribute to health, but also sponsor community building and shared resources, because oftentimes when we have resources going to certain groups that we think need it, expanding those resources will actually build more community, and your neighbors know each other, and then we're not so, those divides, those cultural divides aren't so wide. And in our professional institutions, especially as biomedical researchers, it's very important to increase diversity in STEM. I opened with my personal experience growing up in San Francisco, and that informs my lens. It's a unique lens. And so I'm able to formulate certain scientific questions related to this because of that experience. So our lived experiences are really important to have a seat at the table to develop more ideas, more research questions, and to solve this problem. And my hope for all of us is essentially just to acknowledge that racism permeates every social institution, every arrangement, policies, interactions in the US and around the world, and that it negatively impacts our well-being. So I encourage you to reflect on what we've covered today and to ask yourself, how is racism operating here throughout your careers and your lives? And with that, I will take the opportunity to acknowledge all of my collaborators and supporters, amazing group of people that have contributed to this work and to the advancement of this field of research. And I'd like to thank you all for listening. And I look forward to hearing your thoughts, questions, and hopefully a meaningful discussion. And with that, I will close.
Thank you, Marilyn. Dr. Thomas, for that incredible presentation. It was very thought-provoking and informative. Thank you again. I can see how the audience is incredibly excited as well to have been part of this presentation. I'd like to, if possible, ask Dr. Gretchen Kaiser to actually ask a question that she has in the chat, which I think it's important to sort of express in person as it relates to our funding agencies. Dr. Kaiser, can you ask your question, please?
Yeah, certainly. Good afternoon, everyone. Dr. Thomas, I really enjoyed so many aspects of your presentation. And apologies for not being directly on camera, but internet issues. But what I wanted to think about is you presented that lovely table from the Atkins-Jackson paper that talked about measurement and methods that really need to be changed. I mean, basically, we are kind of saying these are best practices, and I'm just wondering to what extent any of our funders, and for us primarily NIH, but not just NIH, are they taking in these best practices in the description of what they're essentially requiring in the analyses done with funds from their grants?
I think that's a great question. I can only kind of share my experience on how things have changed because, like I said early on, I mean, 10 years ago, I was still having conversations with some of my peers about whether racism was even a social determinant of health, right? Having those conversations, like, is this thing even a thing? And so now the culture around what's considered fundable related to racism related research is so different. Yeah. And it's changing. And also where we can publish. I can't tell you how many medical journals I've been excluded from and immediately, rejected publications just because of the exposure. So I think the short answer is given how the global movement, the social movement that's changed since 2020 around understanding how racism is actually operating to change or to negatively impact health, I think it's just recently that it's even getting attention in the biomedical community in a way that feels like or that's being accepted as valid research. So I suspect that certain institutions in the NIH are going to be much more interested in seeing applications of people thinking about structural racism as a social determinant and applying it in their funding, grant proposals. I've certainly found that to be true. So I can't really speak necessarily to like how overall I think it might change, but I can tell you from my personal experience and my colleagues that we are getting a lot more interest and invitation to present ideas than ever before. So
that's hopeful. I'm glad for that, and just would encourage any and all on to advocate for the change in actual RFA language, etc.
I agree.
Thank you very much. I think, unfortunately, we are at the top of the hour, but we can certainly ensure that the audience can communicate and connect with you, Dr. Thomas, outside of this presentation for additional questions to address. And once again, thank you so much for such an inspiring talk.
It was my pleasure. Thank you for the invitation and best of luck to you all. You have my email. It was a part of the presentation. If you have any follow-up questions or ideas or just want to talk, please contact me.
Thank you. That concludes our session.